All right, heart block. So again, conduction from the top down. We see the atria conduct. We're talking about the P wave. And the P wave, between the start of the P wave and the QRS, represents the time it takes from that P wave to essentially fire and for the impulse to get through the AV node. The atrial tissue is also added in that, but in almost all people, some people that have had ablations and there's some rare diseases where the atrial tissue could have delay, but generally speaking, you're not worried about the atrial tissue. You just worry about the AV node and why is that slowing down conduction so much. So in this case, this is more than one big box, right? More than 200 milliseconds. And so that's delayed. So that's a first degree AV block. Cool? Second degree AV block. So why is it important to separate a second degree type 1 and a second degree type 2? Anybody know? Pacemaker. So this will not get you a pacemaker, and this will get you a pacemaker. This could get you a pacemaker if you're symptomatic, but generally speaking, it won't. So, and this will also not get you a pacemaker. So basically, draw a line through here. Anything down here is pacemaker, anything, well, I shouldn't say anything. These two are pacemaker, these two are not, okay? So to a wanky bach, what happens? All of us have wanky bach, all right? This might be a revelation to you, and I hope that you can sleep tonight. But if we go to the cath lab right now and we start pacing your heart, eventually we get to the point where, I should never say all because there's probably some people that don't, but eventually you get to the point where if you pace it fast enough, you get this type of a wanky bach phenomenon. And what it is the AV node is saying, all right, I'll take this impulse, but I'm going to be a little slower to take the next one. I'm going to be even slower yet to take the next one, and I'm not ready for that. And I'll reset. Now it resets, and now it's like, all right, I'm good. I can take the next one quick, right? So the next one goes through quick. Next impulse comes, it's a little delayed, it's a little slow. Next one comes a little slow, the next one would have been dropped. Right? So that's wanky bach. That's normal physiology. The difference, what makes it abnormal in people, is that some people do it at an unacceptably low rate. You guys might be doing it at a heart rate of 180 or so. But in this case, this person's heart rate is normal, but yet they're still having wanky bach. This can be tolerated, right? Though they might feel skipped beats, but some people might get short of breath and whatnot. So sometimes you might have to decide if you need to do something therapeutic. Mainly what you do is stop any medications that might slow down conduction through the AV node. So those would be beta blockers, calcium channel blockers, digoxin, and Adenosine, right? I mean, I hope you're not taking Adenosine regularly, but that's the ultimate slowing down conduction in the AV node. All right, so that's type 1. Type 2, so again, what we're looking for is, do they need a pacemaker? So you look at that PR interval, same, drop, right? And it would do the same thing, same, drop. And so that would be wanky bach type 2. So whenever you see a dropped beat or non-conducted beat, you're trying to decide what is that coming from. If I got rid of this, and I showed you this, there's a couple options. One is that this is an early beat if it came here, and the AV node wasn't ready for it. And that can be acceptable. It depends on how long the refractory period of the AV node is. And that could be a reasonable thing. So that could be a non-conductive PAC. So that's one thing to think about. If this was gone, it could just be that the sinus node is diseased. And that's another thing to think about. But if you have a P wave that is coming on time, and these PDB intervals can vary depending on what you're talking about. But overall, this marches out, right? And so that P wave comes on time, but there's no QRS. So that's a block. And in this case, it's a second degree block because these ones are conducting. And so when you have a second degree block, now you got to decide, is the PR interval staying the same like it is here, or is it prolonging like it is here? So PR prolongation, wanky bach, second degree type 1. PR staying the same, second degree type 2. All right? That's a memorization thing. I don't know how else to really put that, but that's just how it is. Third degree block. Now you can have incomplete AV dissociation where sometimes the conduction goes through the ventricle and sometimes it doesn't, depending on the disease in the AV node, and that happens. This is kind of, in a way, like an AV dissociation, or like flutter. Not all the impulses go through and flutter, but it's because they're too fast to go through, right? So it's kind of like an AV dissociation. But when we're looking at this, if we see what looks like a third degree, but yet every once in a while it captures, that would be incomplete AV dissociation. Usually if I'm referring to third degree heart block, that would be complete AV dissociation, meaning there is complete cutoff between the top and the bottom chambers. And so you see the V march through, and it's wide because it's coming from the ventricle in this case. It could also be coming from, if it were coming from the top, it could be coming from the junction. If the junction were giving an impulse, you would expect it to be narrow, unless if there was a bundle branch block. So in this case, it looks like it's wide. It's probably coming from the ventricle, and it's firing at what we talked about as the ventricular backup rate, right? So that's appropriate. And then you have to see the P waves that are marching out through the rhythm strip, and they're independent of the QRS complexes, right? That's third degree heart block. That is something that's important for you guys to be able to recognize. And I think generally speaking, those are usually pretty straightforward. This also something that we need to recognize because those patients need pacemakers. So if you're seeing dropped P waves, we need to decide why is the patient having dropped P waves. All right, some examples. So let's say, what is this? This is a little tricky. I didn't say exactly what this is, but you're seeing dropped P waves, right? So whenever I see this, I'm immediately looking at these intervals to decide if they're staying the same or changing. And in this case, the overall distance between these beats here is different, right? So I don't think this is third degree heart block, because if it were, I would expect these to come at exactly the same time all the way through. So you'd expect one right there, and you don't see it. And so I think, and again, this is EKG, so it's not 100%, but I think that these are conducting through. Then the AV node says, that's way too early, I'm not ready for that. I'm still not ready because I have disease, and now I'm ready for that one, right? Not ready, still not ready, I'm sick, and now I'm ready. So this is what the AV node is doing. Over here, it took even an extra beat, so it's a fourth beat, and then that one went through. Here, this one went through early. So whether there's medications on board that are affecting the AV node, or some sort of AV nodal disease, something is wrong. So first of all, you stop them at those medications, see how the patient's doing. But this is probably a more advanced AV nodal disease and might need a pacemaker.
So what would you call that then?
This would be AV dissociation, incomplete AV dissociation. I would probably list in the chart as like a high degree AV block. It's like an AV. You can't say for sure if it's a type 2 or type.
Paramedic that down a bit.
Yeah.
So if I have a patient that's presenting, if they have something like this, what kind
Yeah.
of signs and symptoms am I going to expect?
Here you could just say AV block, basically.
That's what I was looking for.
Shortness of breath, lightheadedness, maybe chest pain, depending on what else they have going on.
Okay.
That would be the most common. They could pass out, for sure. Hopefully not. The thing to look for, when you ask that, is the AV dissociation stuff, is I'm looking at, actually these two beats are important. Because if I have PR interval is the same, right? And then a drop, this is probably second degree type 2. But you have to have consecutive beats to prove that, right? If you only have this part of the rhythm strip, then you couldn't say for sure if it is second degree, you don't know if it's Wenckebach or type 2, because you don't have two consecutive beats to compare that PR interval. But chances are, if they're dropping this many P waves, there's some bad disease that they're going to need a device, generally speaking. Some people, it's just a matter of stopping their medications. But so that's that. Now, what is this? So wide complex, right? This first thing one of the first things you need to assess is it narrow or wide? It's wide. And the QRSs march through. The P waves march through. And so this is third degree heart block, right? So what do we have here? P, QRS, P, QRS. Do you see any dropped beats? No? It's regular. And the P, start of the P to QRS is more than one big box. So that is first degree.